this is a sort of a pilot of this particular presentation, and I'm embarrassed to say that among all the presentations I've ever done, I've never done one that looks at the issues of persons who are older than 50 or 60 years of age in terms of HIV. And it is a unique new field that is evolving daily, and I think it's something we all need to be made aware of. It isn't so much what happens to our bodies, but it's what happens to the people around us and the caregiving that actually predicts success in living well with HIV disease. HIV is a really strange infection in that for some reason it lulls us into thinking we've gotten to a point of either success or failure. We need to turn around and go a different direction, or we need to pursue a new direction more rapidly. But we tend to forget the lessons we've learned from other experiences, particularly in healthcare. There is absolutely no reason to wonder why this disease is aging. We know people are living longer with therapy. If people live longer with therapy, they will be here in 5, 10, 15, and 20 years, and they will age with HIV disease. And I think there's been it's not a conscious attempt at ageism, but it really has been fairly much ignored, and there's very little published data, which makes presentations like this, where I'm used to using a lot of published data and peer-reviewed data, it makes it a little more difficult because some of the information is somewhat anecdotal, some of the information is experiential in terms of me or other people who've had that particular. The risk factors for HIV infection in persons over 50 or 60 years of age, and the reason I'm going to go back and forth is there really isn't a real definition about what constitutes being older, being elderly, being senior, but the Centers for Disease Control actually use a calculation of around 50 in a lot of the statistics. That makes it a little bit easier to say that. Some other publications you'll see say 65, so there's that kind of gap between there, but the risk groups are the same for persons who are over 60 or under 60. They don't vary. Although the percentage of individuals who have injection drug use and the percentage of individuals who attest to being heterosexual are changed within the group itself. The Centers for Disease Control estimates that there are about 26% of all people living with HIV disease are over 45 years of age. And in those individuals, 53% of them are Black Americans and Hispanic. Those risk and ethnic groups bring with them their whole issue in terms of problems that is not unique to age, but one in which access to care is a real problem. The trends that we're seeing with aging in HIV are that antiretroviral therapy has made a tremendous difference. And despite what you may or may not feel about treatment or antiretroviral therapies, it's very difficult not to say that we've had a lot of success in treating people with any number of medications. And the mortality and morbidity, irrespective of age group, has really improved tremendously. Having said that, then we're seeing a number of older people who are entering this, they become infected with HIV and they're entering this pool, and they're doing so actually at a disproportionate rate given the size of their population. In 1998 to the year 2000, new cases in the older population increased at a rate of about 16%. And that's actually high if you look at the same time period for what we call reproductive age individuals, meaning 13 to 49. I don't mean that people are getting pregnant at 13, although they possibly could, but that's how the CDC kind of looks at that particular demographic. It was only 12% in that group, so there were more people in the elderly group who actually, the cases were increasing in that group. And if you look at the individuals, 14% of them were male, and 25% of them were older female. The other group, which I think has gotten short shrift in terms of research and in terms of just social services, are women with HIV disease. And we need to constantly think about being inclusive of men and women in research studies, and as I'll come to a little bit later, some of the disparities we're seeing about the lack of research for people who are over 60 years of age, clinical research. In Black Americans, age 45 to 54, it's the third leading cause of death. In older Black Americans, 15 to 64, it's the 10th leading. And it doesn't mean we're improving from the 40s to the 60s. It just means that basically there are other chronic diseases associated, particularly with Black Americans, in terms of hypertension, cardiovascular disease, diabetes, are more common in that group. It's also a little disappointing to see the next number, and that's the percentage of individuals who claim to have, quote, unknown transmission. Certainly some of those people do have unknown, but a lot of the problem we're seeing with claiming a true factor for risk for HIV has more to do with the fact that people may be personally afraid to attest to what their real risk is. They're embarrassed, or more importantly, in the field I work in, I find that a number of providers are really very reluctant to ask difficult questions of patients, and they can't seem to find a good way of doing this gracefully or in a way they get information back from the patient, but it's critical that we do that. In older persons, the percentage of men who have sex with men is about the same. And I say that because it's so much information that was generated on men who have sex with men for the first 10, 15 years of the epidemic, to the exclusion of women and other groups as well. That's changing now, but it's still the information databases on men who have sex with men and are over 60 years of age is extremely small. There's very little data available on that. And one might think that men over 60 have less sex, but actually in several well-done observational and behavioral studies, the frequency of sex in men over 60 and under 60 is very similar. So you can all rest easy. You're not going to lose that ability as you approach 60. What isn't true, though, is that men who have sex with men and are older don't have a decrease in number of partners. They actually report multiple partners, just like men who are younger than that do. Some disappointing parts of that, though, is that some of the messages are not as clear to the older population as it might be to the younger population, particularly condom use. Condom use is really poor in men who have sex with men and are older than age 60 to 65, and there are a number of reasons for that that we'll look at later. Injecting drug use, again, everyone doesn't necessarily link that to being older, but it is the third highest risk factor in that age group. And again, in men, there was a 53% increase in the 5-year period from 1991 to 1996, and in women, a full 75% increase. Now again, the numbers are smaller, so you can't necessarily just take that and think there's a huge increase, but it's a trend we're talking about. We want to keep a handle on that in terms of groups that have not been well represented in care or in research. In 1998, 15% of males over 50 listed heterosexual contact as their only risk factor. And actually, men who have sex with men, the incidence stayed level in that period of time, but heterosexual risk increased tremendously in both men and women, upwards of 100% in both groups. And again, the numbers aren't on the slide, so you can't take those actually into account with this, but that's still a significant increase for both groups. 10% of all AIDS or HIV cases are in individuals over 50 years of age. Why has it been so difficult for us to determine the real rates in people over 50? It seems like there should be more as people are getting information out about how to prevent HIV transmission and then how to be treated if one does have HIV disease. People over 50 routinely don't test as often as people under 50, particularly men who have sex with men who tend to their credit, screen or test on a regular basis. But when you don't go and get the test, then the group is not really well defined or well represented. Unfortunately, most adults over 50 who now present at a later stage in their illness, and this could have been avoided, and they could have had a number fewer hospital admissions or serious illnesses had they gone in an earlier stage. They tend to be seen for a complication of HIV disease as opposed to those who are seroconverting or in the first 2 years of their HIV condition, HIV infection. Why does it happen? Well, when one goes from 50 to 60 to 70, the number of chronic diseases that we're susceptible to, non-infectious, including hypertension, renal disease, kidney disease, liver disease, they all increase, arthritis. And it complicates the definition of HIV infection in those over 50, AIDS-defining illnesses versus those that are not age-related at all. In addition, so-called B symptoms, and B symptoms were really just sort of a pot together symptoms like fever, malaise, or fatigue, decreased energy level. Those can be attributed to HIV. They can also be attributed to people who are living with arthritis and other types of conditions, so it's hard to differentiate that. I will tell you in my own experience that it's not uncommon for physicians and healthcare practitioners to tell patients that, well, you're having some pain in your knee or your hip. Well, we're getting old, aren't we? And there tends to be the royal we used a lot. And actually, those symptoms need to be clearly defined. One patient I had who is doing well now actually complained of thigh and hip pain for about 2 years before I ever decided to do an MRI on him. That individual actually didn't have arthritis at all. He had avascular necrosis of the hip, which is a condition found in HIV. So I think you have to look a little further. Providers need to ask the right questions. Patients need to be more vocal about particularly symptoms that are recurrent and chronic. Dementia is difficult enough to diagnose by yourself, I mean just by itself, with or without HIV infection being involved in all, but we do need to look at a better definition of what constitutes dementia in HIV infection. It often gets lumped into a category called HIV dementia or HIV encephalopathy. Those may not be appropriate terms at all. That hasn't been looked at in a real clear way. And part of the reason it hasn't been looked at well is a lot of those individuals are 50 and over, and they're not included in the research we're talking about. Again, this late diagnosis and co-infection and comorbidity may speed progression to development of HIV infection or AIDS. The comorbidities are really those of chronic disease such as hypertension, diabetes, pneumonia. It's very important, for example, in a person who's at any age, but say a person of 55 to 65 years of age who presents with pneumonia, there's a tendency to say, well, gee, that's community-acquired pneumonias occur in people in that age range, and we'll treat them for that, when in reality they might have a condition such as pneumocystis pneumonia, which needs to be treated somewhat differently. There are some other issues, too, that come up in terms of being over 50. Stereotypes are there for the taking, and that's actually true a lot in HIV of all the risk groups. In general, though, the stereotypes are applied in the opposite way than they are for people over 50. People over 50 or 60 years of age, quote, are too old to have sex, and they're too square for drugs. And any of you who've worked with these patients in the past know that they're just like everyone else, and there's total heterogeneity of different groups, and you really can't make those types of assumptions. I do know that in physicians I work with, the residents in internal medicine at Good Sam, we work with them to learn how to ask questions that are difficult to ask, and we don't make assumptions because a person looks a certain way when they come into the exam room. Just because a person is disheveled and not clothed well versus a person who comes in a business suit and looks as if he or she is well healed, both of those can be at risk for HIV infection. And there's simply no way to look at a person and tell that I know of, other than asking individual questions that allow us to be part of that person's health care and be privy to that type of information. But that does take trust, and takes asking the right questions in the correct way. People, and I think this is actually, again, an area where there's a lack of research, but in general, it appears that people over 56 years of age may be less knowledgeable about HIV infection than 20-year-olds are. And if there's a reason behind that. One is that if elderly people, if people over 50 or 60 choose to listen to the messages or not, they may or may not. The messages may not be appropriate. A lot of them are geared towards younger individuals, and that actually is great. We want that at-risk population to be educated and to be serotested for HIV and to be treated for HIV infection if necessary. But we need to make sure that that knowledge goes out to older individuals as well, so that they can protect themselves appropriately. Injection drug use over 50, again, this is one of those issues where some doctors will tell you they can look at a person and tell if that person is an injection drug user or not. And again, there's no real good way to do that other than talking with the patient themselves about that. Barriers to prevention in men who have sex with men over 50, that's about the same percentage as it is in men under 50. The cases are much larger, but they're about the same percentage. In the gay population, as in other groups, there's a real fixation on youth and sort of the problems of aging and trying to stay at a younger age. And, older gay men will tell you they feel invisible in social settings sometimes. They feel as if they're not really there anymore, and they're coming from a time in their life when they actually were quite involved in efforts in the community and social efforts or whatever. And this invisibility is really bad because it drives people to perhaps have sex in settings that are not as safe. It may put them in settings where they really can't talk to the individual partner to find out if that person's infected with HIV or not. It's just not a good situation at all, and it complicates our care of HIV disease. If I'm quiet and stay in the corner, I won't get noticed, and then I can get out of the situation very quickly. I think that's a problem with people with HIV disease or people who don't have HIV disease. If you followed from the say mid-'80s to the mid-'90s, the prevention messages that were there were mostly prevention messages that dealt with white gay men. If you look at the literature, it's primarily aimed towards them in terms of pictures or images. If you look at the reading level, it wasn't thumbprinted or brought down to a level, say, for 7th or 8th grade or 9th grade. It was sometimes at a college level, and it was definitely meant to appeal to that group. Those prevention messages really don't do well with older people, and we need to start seeing in educational material, we need to start seeing in pharmaceutical and drug advertising, if they're going to put people climbing cliffs because they're on antiretroviral medication, they need to include older people as well, not necessarily climbing the cliff, but some semblance of recognition that that is a population out there too that's susceptible to HIV disease. When I first moved to Portland in 1980 with my partner from Arizona, there was a real issue. I didn't really understand internalized homophobia. I didn't really know what that meant. I'd never really been brought up to that. But we kind of came to Portland, and at that time it was sort of a change going from a group of older, primarily gay men, to a group of younger gay men moving into the city. And it was we were kind of in the middle. We weren't in either group. But it's a very destructive feeling, and it's something that doesn't allow people, again, to say who they are and say what their risk might be for HIV infection. And I think it's something we should all work to help defeat. In older gay men, it is not uncommon. The drugs of choice are really alcohol and recreational drugs, not injection drug use, as we looked earlier, a smaller percentage. Unfortunately, alcohol, as you probably all know, is a drug that actually causes us to, particularly when we consume it in large amounts, not to make good decisions. And particularly in sexual situations where risk is determined by making good decisions and the right decision to protect ourselves and our partners, particularly alcohol itself may be causing some of the denial of risk that's associated with that. How often do you drink? I drink once a week is a bad question to ask. It doesn't get you the answer you really want to know. And there's a CAGE diagnosis, which is a nice little 4-question item which you can use to look at if people are drinking excessively, that tends not to be used a lot in healthcare as it should be. There's also a whole group of people who are aging. They're going from maybe their 30s and 40s into their 50s and 60s, and they're used to getting attention, they're used to being vocal, they're used to being out. I hope that continues, but what we've seen thus far with people who are already over 50 or 60 years of age is that tends to kind of melt away a bit. What may result from that is, again, the increasing use of anonymous partners and not having sex safely with anonymous partners. In women over 50, again, very poorly researched area, very little information that's useful to kind of take with you when you're working with patients or clients. But generally, one of the concerns about transmission in women who feel they're giving adequate protection against HIV is what happens to the biology of the vaginal wall in terms of thinning and diminished lubrication being present. This actually may increase the risk of HIV transmission, and it's accompanied often by estrogen loss, which also magnifies this. So again, an area that really needs to be looked at that has not been looked at well. I will say some of the best studies that are being done on this are coming out of Africa, where a lot of research is being done where the female population is actually over 50% of the people living with HIV disease in certain countries in Africa. There's some unique issues, I think, that have as much to do with how we see people as the reality of people living with HIV infection. But the whole issue of condom use, postmenopausal women have been through a lifetime where before there was oral contraception, there were condoms, and condoms were used to prevent pregnancy. They weren't used particularly to prevent HIV or any other condition at that time. And a lot of women would say that this is not something they feel they have to use anymore. And again, if not condoms, some barrier method does need to be used, and we need to be more comfortable talking to women who are over the age of 40 to 50 about that. If you've worked with people who are older in the past, you know that sometimes they have a different way of addressing the issue that's not quite as direct sometimes, and it is uncomfortable for them to talk about issues of sex and recreational or intravenous drug use. I have a practice where I try to get my patients to be part of what's available in the community, part of groups, organizations such as CAP and Our House, things like that. And I think in general it takes a little bit of re-education for some people over 50 to really want to be a part of a group. It's difficult for them to interact in the group. It doesn't mean the groups are flawed particularly or they're not addressing the right population. I think it's just a learning process to get people involved. I think support groups are very, very helpful in terms of broadening the base in the community and getting people recognized in the community. I can't stress enough the fact that healthcare providers need to learn to ask the right questions, whether it's about HIV or high blood pressure or diabetes or alcohol use or drug use, whether it's recreational or intravenous drug use. You've got to ask the right questions to have patients feel comfortable enough to answer you. And that's a difficult thing for many providers to do. It's even more difficult for people who are patients to go in and not be prompted to give those kinds of answers. Another problem with the population we have now that's from 50 to 60, 65 years of age is they're often the caregivers for their parents who are 70 to 90 years of age, and that may take precedence over their own health or their own getting to a doctor's visit 4 times a year to have their viral load done. Sounds like an easy thing to do. It can be a very difficult thing to do. Getting fasting blood work kind of involves sometimes rerouting the entire household to make sure one person's been fasting for 12 hours who can then go to the doctor. So this whole role as caregiver and their role within the family itself is something that's important. And if you're going to work with people with HIV disease, particularly those who are older. But what are some of the solutions? And I think basically, again, there's a real need to kind of shake things up a bit in terms of messages and resources. They need to be geared towards individuals who can respond to that particular image, those particular words, that particular method of doing an educational pamphlet. And I think that's an issue that we haven't really addressed very well at all. The targeting older gay men, again, is something that I think is beginning to happen, but there's not a lot of information out there still. And there's a nice study done by ACREA, which is the AIDS Community Research Initiative. It's in New York, a really large sort of community-based organization. They do a really nice job with fairly complicated information. They did a survey of about maybe 600 or 700 individuals with older individuals with HIV disease in New York, and came out with some really interesting things. One was recently widowed or widow or widower, that's male and female, recently widowed. Those may be people who in the last 5 or 10 years of their life have either had maybe no sex with their partner who's ill or dying or whatever, and are now in a situation where they're no longer with a partner and may be considering becoming sexually active again. And I think that's a population that, again, kind of gets swept under the table, and you don't want to have to deal too much with that. But it's an interesting population to look at in terms of developing a program, and it's an interesting population to watch for trends in terms of HIV infection. Anytime a program is developed, there needs to be somebody there who's representing persons over 50. That doesn't mean that every program needs to have every age demographic there, but you need to think about that at least. And is that an appropriate place that we really ought to go solicit someone who's older and solicit them to come and be part of our program, or at least give us input and consultation to developing those programs. Another interesting concept, which I think has worked very well with particularly younger gay men, has been peer educators, training the people to go out into the community who can then give the messages about HIV infection and HIV treatment and diagnosis. I think peer educators may be a bit more difficult to establish with older individuals, again, because of some of the reticence in terms of coming out or providing that kind of charged information. But this whole issue of having someone who you're more comfortable around, whether it's age specific or not, is really important. And then again, just in terms of what pharmaceutical companies have control over, and that's the advertising, whether that is right or wrong, I'm not here to discuss that today. I do think that that's an easy place to put images that aren't necessarily the ones we're seeing now in terms of younger individuals who are extremely active and whose lives have been turned around. I think that's great. We're all really excited about that. But there are people sort of waiting in the wings who are also having less dramatic but very noticeable improvement in terms of their quality of life. And a lot of those individuals are over 50 years of age. Half of what I do is clinical research on HIV, and I continue to be appalled by the fact that for some reason in studies we've decided that 50 or 60 or 65 years of age is a cutoff. We don't want to do research on you. We don't want to include you because you're older and might have other chronic conditions that might complicate our study or might make our drug less likely to be approved. It's really unclear in most studies why we don't include people who are older. If that drug is approved or if that study proves to have a positive endpoint and we're going to use that technique in care of patients, we're going to use people over 65 years of age. They're going to take the medications. They're going to take part of the therapy. So there's really no clear reason, and I think that doesn't even get discussed. They're forgotten in the whole recruitment strategy for clinical trials. The trials also need to have objectives in them that address questions about how HIV disease progresses and how it's best treated in older people. And that's a perfect arena to kind of plant a smaller study or a sub-study or a question or an objective in a trial. And the basic research into intravenous drug use in the population over 50 also is very lacking, although there have been some recent attempts primarily funded by HRSA that do actually get at a broader population group, and I think will give us some of this information. But currently, the state of HIV research in persons over the age of 50 needs work. I think in general, people using antiretrovirals generally respond pretty well to therapy if they're educated about it, if they're well considered. I mean, the right choice is made, not just putting somebody, give them a prescription to go have this filled and you'll be okay. But the other thing we just talked about a little bit, use of highly active antiretroviral therapy in persons over 50, there are some considerations, particularly hepatic or liver and kidney function, and it can cause medications where in an under 30 population, under 40 population, there's really no particular toxicity. You may see a different toxicity in older patients. And again, that's the reason we need to do more research on this population. In terms of protease inhibitors, it does appear that younger people do better with protease inhibitors than do older people, and it probably has more to do with adverse events. These aren't serious adverse events, though. They're not death. They're basically morbidity issues. And I think it's something we have to keep an eye on and watch, but not necessarily something that I would suggest not using protease inhibitors, for example, in older patients. Really deprives them of a very useful therapy, so there's no reason to do that, but you do have to monitor carefully. The other is dosing. What's the correct dose? And we've done a pretty good job with kids in terms of adjusting dosage for medication. We've done less well in people who are older. The other problem that comes with heart over 50 is that it's rarely heart alone, as opposed to a 30-year-old who might be on might be on therapy just for HIV and no other therapies. Patients over 50 are often on hypertension medications, diabetes medications, arthritis medications, and those can interact badly with HIV medicines. So again, the attempt is for providers to talk with patients about what they're using, not just prescribed things, but over-the-counter things as well. So basically, just to kind of finish up, what's the value in having people over the 50 years of age in developing HIV strategies? My parents are both dead, and I feel like I sort of lost that opportunity to talk about their wealth of life experience, but I think there is definitely a lot out there that people who are younger can learn from this population, particularly in an epidemic like HIV infection. These individuals who are over 50 and 60 years of age really are people who can be the teachers and the leaders, and in a lot of developing countries where AIDS is a tremendous problem, that is happening. Younger people, older people, particularly women, are stepping into the role of leaders and teachers for the rest of the community relative to HIV decision. And then sort of my personal bias in terms of research, we need to open it up in terms of populations being allowed to participate and not close it down. Okay, well, thank you very much, and appreciate it.